Okay, good afternoon and welcome everybody to the webinar COVID-19 Ethical Implications and Psychosocial Support in Hospital Care. The objective of the webinar today is to outline the challenges hospital staff face in connection with the COVID crisis. We will discuss some of the related ethical and psychosocial issues, present first experiences and share concepts for potential solutions. The agenda is first an interview with Laura Palazzani on the ethical challenges in the COVID crisis. This has been pre-recorded and questions were asked by Dr. Sabina Madalini. Then there will be a live presentation about psychosocial issues in hospital care, challenges, experiences, and possible solutions by Barbara Yuen and Rachele Brancaleoni. And finally, there will be a questions and answers sessions. You can submit your questions via the chat function of the software, and we will select some of them for answering. Forgive us if we can't answer all of them. And we would especially encourage questions relating to concrete current challenges and potential solutions for practitioners on site. This whole situation is new for us. We extend a warm welcome to everybody and thank you for participating, but we also ask for your patience in case we face technical difficulties with the setup here. I'm Nicholas Eschenbrock. I will be the moderator today, but the webinar has been organized and is hosted by the No Fear Network, a EU-funded Horizon 2020 project, and Niels Elbrecht, who is our host today, will say some brief words about this background. Niels is a senior researcher in sociology at the University of Freiburg in Germany, where he has been working on the sociology of rescue and emergency services for many years. Niels, your part.
Yes, thank you, Nicholas. Okay, yeah, no fear. I will briefly introduce you what is the network about. The No Fear is the abbreviation for the phrase Network of Practitioners for Emergency Medical Systems and Critical Care. Our main objective is medical emergency care, as it plays a key role in assisting casualties after incidents and safety and security implications. And our special focus is that medical emergency care is a very complex chain which is provided by EMS professionals, hospital staff, and all this together and in close collaboration with other players such police, firemen, rescue services, and even citizens as immediate responders. And from all these organizations, actors, groups, we have partners, players, organizations in this network, and it's a growing network. We have more than 100 participants now included. The network is existing since and working together since 2 years. It will be funded for more than 3 years again in the future. So we welcome everyone to join. We see emergency medical response as a pan-European challenge because it is a scattered and complex chain of actors, and we all face new threats again and again. In the first 2 years, our main focus was on terrorism, stabbing attacks, armed attacks, and all the security issues we have to face in these situations as practitioners in the field. Now, since 2-3 months, we've changed the focus a bit to the new threat to infectious diseases, to COVID-19. The network is structured along 3 main pillars. That means we have at least 3 main working groups. One is concerned with the acute care of patients, so the whole chain from from the pre-hospital to the hospital. We have a working group on acute care operations in security-related incidents, and we have a working group on training and education of personnel. All these working groups collect and share lessons learned via our social media, via our platform, via our website, and everyone can, who's registered, take part and use these lessons learned. We all can collect and share current needs. What are current needs? What are new threats and how they are linked to current needs? We also conduct workshops, prepare exercises and demonstrations, and invite different members from the network to join us in these workshops. And we are, of course, very happy to receive feedbacks and recommendations via email or via our platform. So if you have ideas, if you have new solutions, don't hesitate and join the network and become an active member. Yes, and of course, we also have the ELSA work group, which organized the webinar for today. ELSA, this means ethical, legal, and social aspects here, and in this case, aspects of emergency medical systems. The work group organized the second webinar on COVID-19. We had the first webinar 2 weeks ago. You can download and watch it on our platform. It's the first one was more concerned with the first response in different countries in Israel, France, Spain, and northern Italy. The second one now is about ethical implications and psycho-support in hospital care. And this is because a lot of our members in the network are today responding to the crisis in hospitals and experienced different issues, ethical issues, psychosocial issues. And in the last 1.5 weeks, we have tried to collect these issues and to provide first solutions. So the objectives today is to introduce a bit the discussion on ethical issues, but on a very practical level. We decided not to do this on a very theoretical, philosophical level, but to connect the discussion strongly to the challenges in the field, in the hospitals. So a very practical view on ethical issues. In the second part, we want to share experiences and initial solutions for psychosocial support in hospital care. And again, there we have collected a lot of issues coming up, rising up in the last 2 and 3 weeks in the field, in the hospitals. And we have tried to collect them, to raise awareness, to initiate exchange and maybe solutions and exchanging these solutions via our network. That's it from my side, a very brief introduction, and now give the word to Nicholas again.
Okay, thanks, Niels. Everybody's encouraged to keep following the work of the No Fear Network, of course. Our first main point on the agenda today is a live talk. No, is the pre-recorded interview with Professor Dr. Laura Palazzani, who unfortunately couldn't make it today, on ethical challenges in the COVID-19 crisis. Professor Palazzani will be introduced in the recording. She's a philosopher and professor of philosophy of law at LUMSA University in Rome. And questions were asked by Sabina Magalini, who is a senior surgeon at the Catholic University of the Sacred Heart in Rome. And questions were prepared by the Work Package 1 group of the No Fear Network. Yes, I pass on to you, Niels, again for the pre-recorded presentation.
Okay, thank you. I hope it will all work fine. It's a 30-minute record, and after that we will come in a live discussion or a presentation from our other partners. So, should start now.
Good morning. Laura Palazzani is full professor of philosophy of law at the School of Law of the ELSA University of Rome, Italy, where she is director of the Center for Biojuridical Studies. She is the vice president of the Italian National Committee on Bioethics. She is also a member of the International Committee of Bioethics of the UNESCO and of the Committee of Bioethics of the Council of Europe. Professor Palazzani, thank you for your attention today. We wanted to pose some questions which are of importance for the No Fear Network. The COVID-19 outbreak in Italy and in Europe has brought to light the issue of distribution of resources in maxi-emergency situations, when there is an unremovable balance between resources and actual necessity. What guidelines can be provided to responders, physicians, nursing staffs, managers responsible for the distribution of these resources? And in your opinion, are the guidelines issued by the Italian Society of Anesthesiology and Resuscitation correct from an ethical perspective? What are the lessons identified from this ongoing case?
Thank you for these questions. First of all, I need to say that in bioethics, we have a very important topic that is macro allocation and micro allocation. When we are talking about micro allocation, we are talking about selection of patients. But of course, we need to select because we have a shortage of resources. So there were some mistakes, so to say, at the level of macro allocation of resources. So anyway, we find ourselves in this awful situation of pandemic, and the resources are really too short. So there's a big discussion all over the world about the ethical criteria to distribute resources. There is the libertarian model, which says that the criterion is the one of self-determination of the patient and the ability to pay. But this criterion, luckily, isn't followed anywhere. There's another criterion, the one of utilitarianism. Utilitarianism bases on the criterion of cost-benefit analysis, and so the criterion of the number of lives saved, the number of years to life saved, and the quality of life, the so-called adjust life, years of life criteria. And this is one, the criterion applied by the Society of Intensivists and Anesthesists in Italy. I do not share this criterion because I do not think that utilitarian recommendations of selection of patients can be really compatible to the human rights and our right to the protection of health of every patient. So to the principle of equality and equity, which is the main principles of our system of law in Italy. I explain better, because if we apply the utilitarian criterion, of course, we need to make a distinction between the age of the patients. So old patients, and we know with COVID, above all, elderly people are particularly vulnerable. We need to say that old people are out of any possibility to get services and to access to healthcare resources. And we cannot set age as a priori criterion to select. The only criterion, according to me, that is possible to apply in these cases is the criterion of medical need, clinical need, and of course, also efficacy of treatment. In this sense, age is a secondary criterion, not the primary. Of course, maybe patients that are old can have, we may say, a less efficacy of treatment, but not because they are old, because probably they are in a different clinical situation. So according to me, the more objective criterion is the one of medical need and above all, efficacy of treatment. And I should say that there are some other societies in Europe. I make you the example of Belgian Society of Intensivists and Anesthesists that follows this principle. We have a lot of other pronunciation also of ethical committees of bioethics. We are discussing now in the Italian committee, just this Friday, a document that we hope to agree. And there is the French Committee for Bioethics that issued a document that's very interesting. And in that document, also the question of selection of patients is dealt with, and the criterion applied is the one of medical need. So I think this is the most objective to apply in this moment.
We will take the liberty of posing a series of what we consider some ethical questions. These questions have been deduced by we posed other members of the consortium what they wanted to ask on the ethical perspective. So if you can give us an answer according to your experience. Since various countries, as we said, are experiencing the shortage in supplies, especially on personal protective equipment, but also on medication and replacement parts of ventilators and other important instruments, can it be asked to staff to work without given components of personal protective equipment, like, for example, masks, due to the lack of these? Or should staff be asked if they're willing to work, even if there is the possibility that the personal protective equipment is not top rate or not complete?
Yes, it's a question that's more legal than ethical, I should say, but I'm not a specialist in right in workplace, but I can say on an ethical and I also may say on a deontological point of view, that for our healthcare workers, there is a duty to cure and care the patients, above all when there is a state of necessity or a moment of particular emergency, as there is in COVID-19. But we need also to say that there should be a balance between the duty to cure the patients and also the right of life and of health of the healthcare workers. So, of course, the protection of the healthcare workers is really very important in this phase because, of course, if they get ill, we have lesser healthcare workers in our hospitals, and we have a need of healthcare workers. So I think the protection of life and health of healthcare workers is a priority. In the sense that also in the question of distribution of healthcare resources, we generally, a lot of recommendations say that the healthcare workers, because of the risks and the exposure of the risks in their work, they need to have a priority also in the distribution of resources. So they need to be cured and cared, first of all, because we need them also in order to cure the patients. So it's very interesting, recently, a few days ago, the Hastings Center, it's a very important center in USA of bioethics, approved some guidelines that are very interesting also for healthcare workers because they go in detail about a lot of issues, very interesting. And they say, I just quote, processes for employees to report unsafe working conditions need to be settled. So one point is very important that the employees, so healthcare workers, they need to report if they are working in unsafe working conditions. And that is very important and urgent now. Also, I repeat, on an ethical point of view.
This is very interesting. One thing they are doing now in hospital is asking for volunteer work, as though the risks they are making you face is different if you're a volunteer and if you're not a volunteer. I think that is, I don't know how ethical you consider this, if asking for someone to volunteer is sufficient to, unload the responsibility of the management.
No, on an ethical point of view, it doesn't matter if you are a volunteer or a worker. And anyway, you are exposed to a risk, and so you need to protect it in the measure possible, this risk. Of course, we have really in Italy a wonderful example of a big solidarity. That is also people retired are going to work, and of course they are old, and they are anyway willing to expose themselves at risk in order to cure patients. So I think this is really, on an ethical point of view, something that is an example that's very valuable of our country.
Another question that we thought is important from this aspect, the fact that the big difference they are underlining between what happened in South Korea, where the authorities did the swab test on all the citizens, and if they were positive, the authorities put them in quarantine, informing them that they could use all the systems in place, GPS, face recognition, some systems that we are not using in Italy now and in Europe because of GDPR and different privacy condition. Does this example, in this situation for the COVID in a Western society, represent a serious violation of privacy? Because now yesterday, they were saying that this might be applicable also in Europe. So what do you think about this?
So the real problem now is also, in a certain way, political and legal, so to say. Of course, we are experiencing this problem all over the world, and in many countries the political system is quite different from the European and the Italian one. So, but the problem of monitoring and the surveillance of health in this specific situation is of primary importance. So sometimes we say also in philosophy of law, then if you have a threat that's really very huge, privacy can become secondary, because of course you have a priority that is the one to protect the health of the citizens. But anyway, you were mentioning GDPR, and of course we need to mention, because it's our regulatory framework in Europe, and it says something very useful, also on an ethical point of view. So you can use surveillance system with three conditions: ethical condition and legal condition. The first one is the principle of necessity. You need to demonstrate that it's necessary in order to protect health of the citizens. First principle. Second principle is the principle of proportionality. It means that every measure you use needs to be proportional to the objective and aim you want to reach. Okay? So you cannot localize, for example, a citizen 24 hours a day if he or she is not in quarantine or there's no risk or something like that. So you need necessity, proportionality, and of course minimization. That is, you need to minimize the use of data whenever possible. Okay, and so in this sense, for example, in Italy, we applied a lot also the so-called social distance, or better physical distance, as a measure of containment, without applying a specific surveillance. But if we have no results, just trying to engage citizens to spontaneously apply all the measures possible to contain the virus, but if the results are very low, of course, the government can also decide to apply other measures. I was just hearing this morning the TV, and they were talking about the discussion they are doing now about the possibility to apply these new measures. So we don't know. But anyway, I'm sure they will respect these principles. There is a document of WHO that is of 2017. It was written after Ebola crisis. It's a different situation, but there are some similarities, of course. And they told in this document, they write that also in these conditions, confidentiality is anyway a value to be protected whenever possible. So, of course, it's secondary because the priority is the protection of the health of the citizens. That's why I think in this sense, one point that's very important now is also the strong pressure we feel in this moment in Italy, in Europe, all over the world, to the so-called sharing of data, the transparency of data. So we need to share our data. And to overcome all the question about privacy that are very important. But in this moment, we have a lot of an emergency. And so we need to share our data, to be transparent, because this is really a big an important step towards the advancement of knowledge all over the world, and we need that. And so I think we can, there's a strong pressure also on ethical point of view to share data. We are discussing now in UNESCO IBC a document, a statement that is going to be issued in this week, hopefully. I drafted it because I felt it was really important that an international committee could express something in this moment of pandemic. That's a global problem. And one point, I hope it will be shared by all the members of the committee. We are 46, representing different countries all over the world. But as much as I can say now, because it's not published, this document, everyone agreed about the question of sharing of data, because it's very important now.
Thank you. Another issue that is very important for healthcare workers is the fact that these patients with COVID-19 infection are practically isolated. And even when they die or are in the process of dying, they are completely alone, only with the nurse and maybe the doctor that goes in for one moment. This fact impacts on how we look at the end of life for a person, and on the concept that we have always enforced that no one should die alone. And moreover, in some cultures like ours, there are special rituals with having the priest come for the last blessing, the cleaning of the body, and all these things must be skipped now in this situation. What are the ethical implications, you think, related to a death in this time of COVID-19?
Yes, of course, this is a very important issue. And of course, on the ethical point of view, ethics generally says that it's very important, the humanization of death, the accompanying of dying people. That's very important. They feel that the family is near them because, of course, of the fear approaching death. And so that's very important, that psychological support and above all emotional support of patients in the end of life, and also religious support, because you were mentioning rituals. I'm not an expert of religion, but of course we all know that in that moment is very important for the patients that belong to a specific religion to feel also the support of religion in that moment. But now it's not possible. And so we cannot even imagine the consequences that it has, above all for families. It's very important that in the French opinion of bioethics, there is a mention of something that I think it's really interesting in this moment. The French committee recommends the government to set up also a research, not only on the scientific level, of course, we need a scientific research on COVID-19, but also on the human sciences, that is on a sociological and psychological point of view, because we don't know the consequences of this situation, above all on families that lose their parents and children and without the possibility to be near them in this moment. And that is very important to also to study this phenomenon in order to maybe better organize the situation. I watched on television, there was a very touching example of a healthcare worker that just with a telephone, with the possibility to have a video telephone call, they just tried to manage the possibility to communicate between families in this moment. And so it's very touching because really it's the only way we have probably to feel someone near in that moment. And so, and also in the document, the Italian document of the Society of Intensivists, there is one point that's dedicated about the problem and the psychological support to families. And that is when they experience the dying of their parents and so on. And that is very important that also our Society of Intensivists is taking care about this ethical question.
Thank you. Do you think one of the problems also is that many healthcare workers are worried about having old people at home, because here in Italy, many old parents live in with their children and grandchildren. What kind of selection do you think could be done among healthcare workers who are not only at risk for themselves? You know, older people, older doctors are more subject to the disease, and they have died also in Italy, older doctors, but also younger people like nurses who may have their parents at home. In a way, do you think it might be possible to stratify the risk of who is going to work and who is not going to work from an ethical perspective? Do you think the responsibility towards a third person might be something important?
Yes, of course. The principle of responsibility is the first one. So we are responsible towards our health and towards the health of the other. And I think this COVID-19 is just expressing this responsibility, that is this principle that is of ethical value in a very clear way. So, of course, healthcare workers have a duty to cure patients, but they need to balance their duty with also the need and the value of the protection of the family. And so what we are seeing now in Italy is that a lot of healthcare workers do not go home. They stay in the hospital because of this contagion, because of the risk. They don't want to expose to risks their families, and so they don't go home. And that is an awful situation also because, of course, they expose themselves not only to risks of contagion, but also to psychological risks. There is a burnout and the distress of healthcare workers in this moment because of too much work, and they work 24 hours a day without rest, without the possibilities to have a bit of relax, and so in this sense they have a lot of bad psychological consequences. So the principle of responsibility is at the center. And so there is a sort of conflict. It's a real dilemma between the conflict of responsibility the healthcare workers feel towards the patients. They need to work for them. But on the other hand, responsibility towards their own families. And so the only way to get out of this question is only the possibility to not to go home. And for a period of time, at least, of the emergency of the worst crisis we are living in these days, and maybe hopefully things will go better, and maybe there's the possibility to better balance these two risks and to find other solutions. Now we know that they cannot even check to all the healthcare workers if their level of contagion. And so, of course, we cannot balance the risks in this moment, but maybe in the future it will be possible, and we hope it will be possible because, of course, we need also to take care about healthcare workers that are in a very stressful situation in this moment.
Thank you very much, Professor Palazzani. Is there something that you would like to add? A personal consideration? Or...
Yes, just I think that now, because your project, the title is Fear, I think it's really, this situation is really challenging for your project because of the fear. And I think the fear is of everyone, of every citizen now, but above all for the so-called vulnerable, particularly vulnerable populations. We are all vulnerable, of course, but there are some specific categories that are more vulnerable than others in the situations. I'm thinking about old people, and I'm thinking about also maybe immigrants that have also a problem of language, of communication, and maybe they don't understand really what's happening, and they are different of their families. And above all, of people with disabilities. And they are fearing to be left out of the cure and cares being so restricted and so short because the perception that there's no possibility to cure everyone is spreading in our country. And that is really a big source of anxiety for everyone. We don't know if we will be cured and cared. We know that everyone is doing what is possible because if we see they are going to transfer patients from one region to another, and they are going to set up new structures in very few days in order to have beds for everyone, to let everyone to be cured and cared. So we have a feeling of gratitude to everyone who is doing whatever they can. There are a lot of effort everywhere to try to solve problems. And so I think that is really something valuable in our country. But anyway, there is a fear. The fear to become ill, but above all the fear not to be cured and cared. And that's something we need to solve. And I think we will have maybe after, hopefully as soon as possible, when we will get out of this problem, we need to have a debriefing and to organize better for the future, because pandemics can become another problem also in our future, and so we need to be better organized, and we need to understand, above all, also on a political point of view, that health is at the center, and a lot of resources need to be spent and put health as a priority, because health is our value. If you are not healthy, you cannot live, and the right to life, the right of protection of health is at the center of a legal framework and also of the ethical framework. So we need to be really aware about that. And I think that COVID-19 is making it clear to everyone, to politicians, to ethicists, to jurists, and to citizens. And that is really very important for our future.
Thank you very much.
Okay. Also, on behalf of the organizers, I would like to thank Laura Palazzani for being available for this very instructive talk, and Sabina Magalini for asking the questions. If you have questions concerning the talk, Sabina Magalini will also be one of the people available later for answering. So again, I would like to encourage you to ask your questions in the chat sidebar, and we will do our best to answer them towards the end. The next point on our agenda is a live presentation by Barbara Yuen and Rachele Brancaleoni on psychosocial issues in hospital care, the challenges, experiences, and possible solutions. Barbara Yuen is a psychologist. She is the head of psychosocial services of the Austrian Red Cross and an adjunct professor of psychology at the University of Innsbruck. Apart from her academic work, she has more than 20 years practical experience as a clinical psychologist and as a crisis manager in a number of mass emergencies and disasters. Rachele Brancaleoni is a health visitor and a CBRN protection specialist at the School of Medicine of the Catholic University of the Sacred Heart, UNICAT. And thank you, Barbara and Rachele, for putting together this talk, and we look forward to it.
Okay, welcome everybody. We want to go now into more of an experience exchange type. So we present you our talk in 3 parts. The first part will be about the challenges that we at the moment perceive in medical staff in hospitals, and this might not be complete. That's just what we are seeing at the moment. The next part will be, Rachele will tell you about the experiences in one hospital in Rome as an example for experiences that are made all over Italy and also in other countries of Europe at the moment. And then we will go to the solutions part, and we cannot present you finished solutions or something like that. The situation is evolving. It's a new situation for all of us. So what we are doing is present you with some of the ideas that we have for possible solutions. Some of the things are already tried out in some of the countries. Yes, that's what we plan to do now. So let's start with the challenges that I said to be faced or faced, because many of you are already facing these challenges. Some of you perhaps are at the moment waiting what will happen in the future, in the immediate future. Okay, let's start with the challenges. The control, thank you. One of the challenges is the triage. On the one hand, we are all in hospitals, we are used to the system of triage. So the triage in itself is not a new concept. What is new is the decision about life and death that has to be taken at the moment in a more public context, I would say. It's a public discussion. People from the public are extremely anxious at the moment about these issues, and they don't really understand how it is done, if it is done in a good way, for example. They think, for example, some of them think that only older people are not given any resources or something like that. So this is a big issue. The next issue that is faced by the personnel in the hospitals is the whole issue of palliative care in isolation. So being the one who has to connect between patients and families, for example, by giving their own phones and using their own phones or whatever, having to bear the emotional burden. So normally you are, in a way, you are protected by your professional distance. But if you are just in between the patient and the relatives in such a situation of dying, you are not able to protect yourself completely from the emotional burden. So this is a big issue. The other thing is that many of the personnel are not really used to work in a palliative care situation. So it's a new situation for many of them. The next thing is the dealing with the dead bodies, how to be able to make use of religious procedures in a context where religion plays a big role for families, but also for the personnel. So this whole issue of how to deal with the dead bodies and how to involve and when to involve and where to involve clergy in the hospital and in the care of the patients and the relatives is also a big issue. The next issue is about fears and distrust between staff of different organizations, for example, between the emergency medical service and the hospital staff, or between families and friends and the hospital staff. The hospital staff and also the EMTs are at the moment experiencing stigma in some ways, like people are afraid of them bringing the virus out to them, yes. Let's go to the next slide. Another challenge that we identified is regarding the PPE resources, because if the resources are finite, like at the moment, if they are not great enough or good enough, the feeling of safety of the personnel gets affected. So the personnel doesn't feel safe anymore. So they don't know if the PPE is protecting them well enough. There are always changing materials. So one day one kind of material, the next day another kind of material, changing procedures, and all these things are producing a lot of insecurity and feeling of unsafety. The next thing is that many doctors have to come from other fields, and not only doctors, but also other personnel like nurses. They come from other fields and they have to be given a short introduction into this new field of work. And this seems to be a difficulty in two ways. The one situation, one way is the trust between the personnel, but the other situation, the other thing is the danger that these people are seriously traumatized by experiencing a situation where they are not really trained for this situation. And the illness in the personnel. More and more people from the hospitals are ill and are COVID positive. They have to be in isolation. Some of the colleagues are severely ill or even dying. So all these things, they give a situation of great insecurity and uncertainty to the personnel. All in all, if I can summarize this, and I think there might be other mental health challenges that we have not identified yet, but these are the main challenges that are spring into your face at the moment, I would say. There is, for the psychologists amongst us, there is this new concept of moral injury. I don't know if you know that. Moral injury is a type of traumatization that focuses mainly on ethical issues that are coming up in a certain situation. And this what we face at the moment is a typical example for a moral injury that we are facing at the moment, and which we have to cope with. Okay, so I think the next slide might be the one for Raquel. Just go on. I don't know, Niels, do you have the controls, or who has the controls? Nicolas, Niels?
I don't have the controls.
Who has the controls?
We have the, and Raquel is turned on, so now she has control.
Okay, Raquel.
Okay, thanks. Yes, well, this brief research was conducted by me and Dr. Sabina Magalini. She's here, so any questions can be answered by both of us. We are both working for the Gemelli Hospital, that is a big hospital located in northern Rome. Niels, what is going on? Okay, so, but in any case, all the views and information or opinions expressed here are not representing the ones from Università Cattolica del Sacro Cuore or Fondazione Policlinico Agostino Gemelli. The experience from Gemelli Hospital, we decided together with Dr. Magalini to structure in the Maslow's hierarchy of needs, well known as pyramid. This was designed in the middle of around 1955, 54, and so we decided to select main problems and structured and present it according to this pyramid. So starting from the base, the physiological needs. So our personnel is clearly working wearing uncomfortable suits. And it's really important when we are talking about thermal comfort, because these suits are critical. It's not comfortable at all, especially also the masks. And the staff is wearing PPE for a long time, usually the entire shift, because of a PPE shortage and also lack of relaxing room dedicated to people who are wearing PPE. Safety needs. So these are the physical safety needs. Then we are going to see the emotional one. So the personnel doesn't feel sufficiently protected, even if we are following all the international guidelines and we are following all of them, but their feeling is that they are not sufficiently protected. As already mentioned, there is a PPE shortage. And as also Barbara said, a lack of trust in internal and external or newly hired workers. One of the doctors said also that nurses or doctors may experience difficulties when one of the staff members would die because of COVID. More looking to safety needs regarding the emotional one. As you well know, relatives are not allowed to visit patients affected by COVID. On the other hand, we have patients that are awake and understand, most of them are awake and understand the moment when they are going to die. So this clearly put the staff in a very, very stressful situation, especially the nurses feel like they have a role of mediation between the patient and the family, because the family cannot enter the room. Sometimes they are, as Professor Palazzani said, they are using the phone of the patient to make a connection between the patient and the family itself. And the PPE shortage clearly affects also the relationship of the staff with patients. Normally, staff is entering their patient room more times in a day, but now it's critical. We cannot use PPE just for entering the rooms. So they feel a sense of frustration and powerlessness because they cannot communicate that much with the patients. Love and belongings, we are scaling up the pyramid. Clearly, the staff is concerned to bring home issues related to their job, and this is a normal situation, but now they are returning back home with bad feelings, with negative emotions, and also sometimes they fear they will bring back home COVID-19, so they will spread this virus. Many of them are living also in the basements, so they are not meeting their family. All the nurses, and these are very very nice examples, are taking over the duties of younger nurses who have kids. And this is a solidarity between staff. Well, the team, few members of the staff are experiencing stigma. This is really important because on one hand, we have applause, they are seen as heroes, but sometimes they are also stigmatized. And when we reach the top of the pyramid, so self-actualization, the staff really hopes that when the crisis will be over, the system and their hospital and the government and the international organization will learn from the COVID-19 pandemic and will not further cut healthcare services. And that's it all from my side. Back to you, Barbara.
Thank you, Rachele, for this very impressive insight into what happens at the hospitals at the moment. I will now come to the part where we present first out ideas about how to support hospital personnel well enough. And what we think from our point of view is you always have to think in 4 areas. So the support has to be always given on all of these 4 areas. The first area is information. The second is clear and commonly shared procedures. And as you see, the first 2 areas are areas that can only be well done by the management, by the leadership. Whereas the second 2 aspects like psychoeducation and peer support and counseling is something that goes into the responsibility of the mental health professionals. So let's go through these aspects shortly. Somebody has to give me the next slide. Thank you. So the leadership tasks, and in this case, I would say one of our tasks as mental health professionals in the hospitals is to do a good coaching and support for the leadership in order to help them fulfill these tasks in a way that doesn't affect the mental health of the personnel in a negative way, more than the challenges already do. So the first is to have good information. This has to come from the management. A good and close cooperation between management and the experts is needed. Otherwise, you cannot do that. You have to do a clear and open communication to personnel. Like, for example, how many people from these hospitals are in quarantine at the moment? Do we have illness within the hospital? How many are ill? And so on, and so on, and so on. And this, on the other hand, the procedures, the guidelines, and the rules how to deal with hygiene, with triage, with palliative care, whatever, have to come from the management and have to be clear and commonly shared by everyone. So if you give me the next slide, I can go in the next. The mental health experts part is about psychoeducation and about peer support and counseling. What we think and what we see is that normally in the hospitals, we need at the moment like a helpline that gives peer support and counseling, and then on the other hand, enough psychoeducative information. This may be in the form of materials or in the form of podcasts or whatever. The peer systems, if there are peer systems, can be used and activated. Psychologists provide individual and group support at the moment. They do assessments, they do psychosocial interventions and psychological interventions for all staff. Mostly they do it via helpline, via telcos, via leadership counseling. So support for personnel in quarantine and this isolation has to be done. So in this area, we recommend to have a proactive approach so that the leadership or the mental health experts, depending on the situation, reaches out to the personnel in quarantine and this isolation actively, and the support for the leadership. So if you see it, look at these principles, these intervention principles, the same principles apply also to patients and relatives. Also here you have to have a good information, clear procedures that are transparent and everybody understands them, psychoeducation, peer support and counseling, and all of this has to be done in a context that we are not used to, like in a context where we have to do most of the support in a context where we do distance support. Yeah, not everything, but most of it. So clergy should be involved, internal and external teams should work together. What I mean here is, in some countries you have external teams supporting the families at home while you have patients in the hospital, and these external teams have to be in close context with the internal teams so that the support can go on in a good way. So give me the next slide. So now I come to the, we try to go from the top to the bottom. So now we come to the more concrete solution ideas in the information and procedures part. It's about regular information for staff on COVID cases, available resources, procedures, staff infection, and so on, and so on, and so on. And as Professor Palazzoni has already said, here we face a lot of difficulties at the moment with data protection, and we have to solve these problems very fast and see that this is a situation where data protection has to be it's important, but it has to be downsized a little bit in order to make us able to work. Clear procedures and responsibilities like triage decisions. Some of the medical doctors would like to have the decision taken in a team and not by an individual, palliative care guidance and whatever. End of shift operational debrief and beginning of shift operational brief, which is a leadership task, where you have to support, as psychologists, for example, you have to support the leadership to be able to do this task in a mental health, in a good way to also, I have a problem with my English words, to look also after mental health aspects. Diffusing, I will talk about that extra, which with diffusing I mean situations where it's not a normal debrief and brief at the end or beginning of shift, but it's something bad happened, like or whatever, and then the team needs some kind of an emotional diffusing, which is and should be done by specially trained personnel. Regular contact to staff in isolation and to their families via management and team leaders. So I mean that this proactive contact, like the organization reaching out to the personnel and how to deal with dead bodies and religious procedures, has also to be in a way organized from the upside down in order to have good procedures, in order to make people on the mental health aspects be able to work. Next slide. So now I come to the mental health aspects and the mental health professionals and peers working in these areas. We need palliative care guidelines, including mental health aspects, PSS guidelines for crisis intervention via web application, telephone, in close cooperation with the teams within the hospitals. That's what we are focusing, for example, in Austria, including nurses, clergy, and psychologists. So the most important thing is also to include clergy in this whole issue at the moment. Peer support systems and psychologists anonymously available within the hospitals, like a helpline. Support and supervision for leadership, and diffusings where necessary. Inclusion of clergy in palliative care teams, I already said that. There are some good guidelines coming out at the moment in the German-speaking countries. I don't know how it is in other countries, about how you could include clergy in this distance context. Yeah, we can put all these guidelines also on the No Fear portal. Contact between doctor, nurse, and patients together with a relative on the phone, for example. If there is a talk between the doctor, nurse, and the patient, perhaps there could be some possibility to include relatives on the phone, the support for other personnel, like cleaning personnel and kitchen. Especially in the hospitals, you have to be very careful not to forget this other personnel. Special support for staff in isolation, I already said that. Proactive approach, already said, and family support, like support for the families of the nurses and of the medical staff, which is extremely important. And at the moment, where resources are a little bit stretched, often the family support comes last. Rachele.
Yes. Back to me. Gemelli Hospital opened a free and anonymous service of psychology. This is reachable via phone or email, and this is particularly dedicated for staff working with COVID-positive patients. Moreover, they are conducting focus group with the EMDR technique for the hospital staff, but they are also arranging a group for EMS. Yeah, that's it from my hospital.
Who has the control?
Yeah.
Niels?
Yes.
We need the next slide.
There is.
Oh, finished. The last slide was about, sorry, the last slide was about, again, about Italy. I talked to my colleagues in the Red Cross, and what the Red Cross in Italy does at the moment is they have a strong focus on the healthcare personnel, especially also the healthcare personnel in EMT, emergency medical services, here. And they offer a 24-hour psychosocial support helpline for their own, but also other healthcare workers, which is given by, at the moment, 300 psychologists via a helpline in 17 out of 20 regions. They try to build it up for all regions at the moment. They go in 4 shifts and they do it 24 hours a day, and they have an extremely high acceptance in the service. Their service is highly appreciated by the healthcare workers because it shows to them that the organization is really caring about them and is really taking care for them, which is a very important message at the moment. Thank you. So now we are really finished.
Okay. Thank you both very much for this quite comprehensive and insightful presentation. We appreciate the time and effort you've made over the last days to put this together for everybody. There's now the opportunity to ask or discuss questions, really. The people available for answering questions will be the 3 people you've heard, Barbara, Niels and Rachele, plus Sabina Magalini, who has been mentioned a couple of times, and you've heard her also on the interview where she was asking the questions. The questions that have been asked so far as I can see, relate to data. The way I take it is that the first question is meaning to ask whether the availability and sharing of data is not really also an ethical issue, which is sort of one thing I would put to our 4 responders. And the second question is, if I can sort of paraphrase it briefly, in which way this the sharing of data could be done, and if there are already efforts underway. Of course, these are rather big questions, but I think they are also important. So the question is, who of the 4 respondents would like to say something about the ethical and practical issues involved with data in this situation?
Well, this is Sabina Magalini. I just bring a personal experience. It is very difficult to share information inside the hospital. You know, I mean, when what colleagues have been contaminated, who you met and where you met him, and the information is basically going through the grapevine. We speak with other colleagues when we change the shift, and you say, you know this, you know that. So I think maybe if hospital management, I know it's very difficult in these situations, but could somehow convey the information in a structured way, it would help people also to have less, to be less scared.
Okay, thank you very much. Anybody else from the respondent team about the question of availability of data and the practice of making data available and the ways of making it available? Okay. I would like to move on to another question. And I think it's probably, even though you can do that as well, easier if I read it rather than try to paraphrase it. The question is about new doctors in the Italian health system. In Italy, the national healthcare system is now hiring physicians who got their degree just a few weeks or months ago and have no working experience. Even if they may will not manage critical patients, even if they maybe will not manage critical patients, do you think they will be prepared enough to manage the psychological impact of working in such critical conditions? So will they be useful at all, or are we just subjecting them to major risks due to lack of PPE or incorrect experience in using PPE? The question of junior personnel has been addressed a couple of times in the presentations. Anybody of the four respondents who would like to take this question?
I can take the question. What I find important in this case are two things. One, about the PPE. These people have to be protected as well as anybody else. So that's the one thing. But regarding mental health issues, I would say the most important thing is, if you bring in new personnel that's not very experienced, you should really take care of where you bring them in. You don't bring them into the hotspots, but more to other parts where you need resources. And what in other cases has been good is to have some kind of buddy system in place, like more experienced personnel feeling a little bit responsible for the newcomers and having an eye on them, like supporting them in a way like buddies, and giving them access to all the support system that is present in this hospital. Perhaps also to have an extra helpline for those for this especially vulnerable group. But on the one hand, we also on the other hand, we also have to see that bringing in this new personnel is also a way of giving them a chance to be also active in this crisis situation, and this is also empowering them. But on the same we have to empower them on the one hand, but on the other hand, we have to protect them in a physical but also in a psychological manner. That's my opinion to this question.
Somebody else from the respondent team, or should we move on? There's a question also that I think is especially relevant in light of the No Fear network, which is the question: how could we increase European coordination regarding preparedness and response? What are your ideas in the responding team? What would be necessary first steps maybe for European preparedness, both on a practical and a political level?
Well, at this point, only gathering information to do a lesson, knowledge management and lessons learned in the next few months, because now, at least here in Italy, we're so much in the middle of an emergency crisis that it is difficult to do anything else than to ask for help. This is what our government is doing. You can see it on the newspapers. So the moment to, as Barbara said, to do the debriefing, I think will come. But the thing is now to collect all the information that is possible. I think that's the only useful thing. Also, what is happening in Spain today is, I don't know, how can you ask them for anything in this moment? It's
But maybe since a couple of questions were about the availability of data and data systems, from a practical point of view, what could one realistically hope for in terms of future data management? What would be steps that you maybe think would not be so difficult to take, but would have a really important impact? I realize I'm pushing this on to you, maybe asking too much, but
very difficult. For example, I do the closing of the clinical charts, electronic health records. 3 days ago is the first time that the Italian Lazio region sent us the codes to close the COVID-19 cases. Okay, so information sharing depends on how much information you put in to see what you're getting out. So in a way, to use the tools we have, incomplete, insufficient, at the moment, to put in all the information we can now with what we have. And in a second time, if there was, I don't know, someone from the European side that could take the burden of saying, okay, I'm going to collect all this information for you, but not adding extra work to the healthcare structures in this moment, which is very, very difficult. Maybe that could be useful, like because we're reporting to the national committee, which is giving us information every day at 18 p.m., 6 p.m. on how are the data flowing, the deaths, the contagions, and then I suppose there is this information is going to the ECDC or World Health Organization. This I don't know from my level where I work, but from our side, the practitioners to put all the information together, gather it, and in a second moment, we will maybe be able to do something on that information.
Okay, thank you very much. Since there are no more questions at the moment, I would maybe like to take the occasion to give the respondents a chance for a closing remark. The 4 people we have on the team here, a closing remark regarding maybe lessons learned from this webinar, regarding next steps, regarding your personal situation relating to research in this situation. So if you like, I think we could maybe conclude with closing remarks from your side. Anybody, what would you still like to share before we adjourn?
Yeah, I just could, so Niels is speaking, I just can't take up the last question, what can we do now, and what Sabina discussed before. I mean, the one thing we can do now is using networks like this one and try to share information and concepts as fast as possible. Give them, to try to discuss them if it's possible, to reflect them as far as this is possible at the moment. And I think this is the contribution we as networks can do at the moment. What will happen in 1 month if we can have some kind of initiatives to collect data, we will see in that. But I think there will be new networks and new organizations who want to take up to draw on this material and to give it maybe a better form, a better organization, a better spreading, better dissemination practices. We will see.
Okay, more closing remarks on behalf of the team?
Well, one from my side, since this crisis is is running, and we don't know when it's going to finish or whatever, we're going to collect this webinar as the relevant documents regarding COVID-19 in the portal, so you can access the portal and have a look at them.
Thank you. And as there is now coming up the question how it would be possible to stay in contact. I understand that it is possible to become a member of the No Fear Network, and I would like to point out that there will be potentially new webinars coming up, and I would ask everybody who has been here today to continue paying attention to this work. I would also like to thank everybody who has been involved in the preparation. I came in quite late, but I realized a lot of work by more than half a dozen people went into making this webinar possible. So thank you very much for the work you've put in here. Thank you everybody also for attending. It's encouraging that there is this amount of attention for our work. Please spread the news, and at this point have a good day, stay safe, and stay healthy. Thank you very much.
Bye-bye.
Thank you. Bye.
Thank you.
Bye.